All right. Good morning, everybody. My name is Choudhury. Most of you know me as Sai. I'm one of the PGY2 EMIMs. Um, I'll be presenting on a retrospective study today with a theme of resuscitation. Special thanks to Dr. Benabbas, who will also be delivering part of the lecture with me, Dr. Buckley, and the rest of the EBM team. Without further ado, so the study that we're going to be looking at today is a retrospective study, moderate IV fluid resuscitation associated with decreased sepsis mortality. So in this study, Corey et al. Conducted a retrospective analysis of an already existing database to examine the relationship between the volume of fluid resuscitation and mortality in patients with sepsis and septic shock. The study included almost 200,000 patients with sepsis and septic shock admitted from the ED to the ICU from 2016 to 2019. The primary outcome was hospital mortality, and the primary independent variable was the attending fluid group based on resuscitative IV fluids administered before the end of hospital day one. Um, the authors ultimately found that patients grouped under the moderate resuscitation attending group, median received about 4 liters, had an associated decrease in sepsis mortality compared to patients who were in the either very low, median about 1 and 1.6 liters, or very high, 6.1 liter fluid resuscitation groups. So the authors found that patients grouped under the moderate resuscitation attending group, who got around 4 liters, had an associated decrease in sepsis mortality compared to patients who were in the either very low, who received median 1.6 liters, or very high, median 6.1 liter fluid resuscitation. The authors also observed significant variability in IV fluid resuscitation and sepsis, which they then attributed to individual attending variability. They built a model to predict the mean amount of IV fluid that should be administered on hospital day one. This is referred to as IVFD1, based on patient characteristics present on admission, demographics, conditions that might trigger IV fluid resuscitation, and factors that may prompt withholding IV fluid resuscitation. So based on their model, they predicted that physicians should have administered a narrow mean range of IV fluids on day one, 95th percentile being 3.6 to 4.5 liters. However, the authors also observed a wide variation of the mean IV fluids given on day one in clinical practice, ranging from 1.7 to 7.4 liters, suggesting significant variation in physician practice regarding fluid resuscitation in patients with sepsis and septic shock. So the final conclusions were that the significant variation is primarily due to physician practices, and that they believe a moderate approach to IV fluid resuscitation should be tested in future randomized controlled trials. Um, okay, so methods. They use de-identified data blind to patients, physicians, and hospitals obtained from the Premier Healthcare Database from January 1st, 2016 to December 31st, 2019. The database includes detailed billing for almost 20% of US hospitals. Um, the researchers primarily used ICD coding for sepsis and septic shock to find inclusion criteria for these patients. And additionally, sometimes they would use coding that would code for acute organ dysfunction present on admission, as well as infection, to try to catch cases that may have been sepsis but weren't coded as sepsis. Additional enrollment criteria: patients were at least 18. They had to go from the ER to the ICU on hospital day one. They had to have gotten IV antibiotics and IV fluids on hospital day one. And hospital day one refers to the first day of record with a hospital room charge. Um, they also included patients who received IV fluids in the emergency room before hospital day one, which included about 11% of patients in the study. Exclusion criteria were due to the following categories. So hospital-based. So if the hospital had less than 20 cases, they weren't included due to sample size. And hospitals where more than a quarter of patients got less than 500 cc's of IV fluids on hospital day one, suspecting underreporting. Patients who are DNR, going through surgery, received less than 1 liter of IV fluids, as it is unusual per the study authors, or IV fluid based. Patients who are transferred from another facility, assuming that they were resuscitated at that facility, and patients who are getting IV fluids with just carrier fluids for other medications. So, in terms of the measures and analysis, the primary outcome was hospital mortality. So, how did these patients do? The primary independent variable was the attending fluid group based on resuscitative IV fluids administered before the end of hospital day one. Secondary outcomes were use of vasopressors, mechanical ventilation, diuretics, and initiation of new hemodialysis. So how were these obtained? Multivariable linear regression, including an analysis of variance, was used to predict the average fluids a patient should have received based on characteristics that were present on admission. So these include age and sex, things that trigger IV fluids, such as having like electrolyte disorder or acute organ dysfunction, and then things that might prompt withholding IV fluids, such as ESRD, CHF, pulmonary hypertension. They then use this output to examine the attending physician mean residual, which is basically the observed minus the expected IV fluids that were given on hospital day one. So based on this mean residual IVFD1, attendings were placed initially into 9 equally sized groups, but then the study authors consolidated these groups across 5 groups to make the groups clinically distinct. So you have a very low group, 11%, a low group, 22%, moderate, 33%, high group 22%, and the last 11% were in the very high group. For the primary and secondary analyses, logistic regression was used to risk stratify outcomes for each attending group into high and low severity groups, which were then adjusted for the demographics and the severity of illness present on admission. And there were also subgroup analyses for patients who required vasopressors, patients who had CHF, ESRD, pulmonary hypertension. And then these outcomes, primary and secondary outcomes, were then compared using students' t-tests for these groups. And then lastly, to try to figure out if the differences in mortality associated with the IV fluids on day one were attributed to physician practices within a given hospital or differences between hospitals, a fixed effects logistic regression model was used that included hospital identification number as well as patient variables included in the primary analysis. So some figures from the study. So on the left, you can kind of see this orange line, and that was basically the model that they would predict. Basically, a narrow mean range of IV fluid should have been given, but in actuality, the fluids were actually kind of given to patients going along the blue line. So when you control for the baseline patient characteristics, the model predicted a narrow range, about 3.6 liters to 4.5 liters. And we kind of already discussed the ranges of the fluids given based on these different groups. And they found that the fluids given across these groups were significantly different, p less than 0.01, compared to the moderate group. Physicians in the very low fluid group actually gave 2.2 liters or less, and physicians in the very high group administered 2.9 liters more than what the model predicted they should have given. And if you look at the chart look at the graph on the right, where it's kind of showing you the breakdown of patients across fluid groups, there was another example of wide variation, given that 80% of patients in the very low fluid group received less than 2 liters of IV fluids on hospital day one, whereas 46% of patients in the very high fluid group received greater than 6 liters of IV fluids, and 10% received more than or equal to 11 liters of fluids. Now, when we're talking about the outcomes, patients in the moderate fluid group experienced a reduced adjusted mortality compared with all other fluid groups, minus 2.5%. And again, this was found to be significant, p less than 0.01. So these observed differences in mortality persisted, but were smaller for the lower severity and sepsis without day one vasopressor subgroups, and were larger for those in the higher severity and sepsis with day one vasopressors. And that's kind of what this chart is showing. This graph is showing, pardon me. Examination of risk-adjusted mortality for the first 8 days also showed that mortality benefit associated with the moderate fluid group was present at the completion of hospital day one and increased each day until day 6, after which there was no significant increase in magnitude of the mortality benefit. They also found that physicians in the moderate fluid group gave less median IV fluids to patients with pre-existing conditions such as CHF, ESRD, and pulmonary hypertension compared with the total cohort. and patients ended up having reduced mortality compared with the very low or very high fluid groups. And they also found that patients in the moderate fluid group were also found to have required a lower risk-adjusted rate of mechanical ventilation. Lastly, researchers also saw that physicians who administered a very low IV fluids on day one did not prescribe a higher risk-adjusted rate of vasopressors, while physicians who gave a lot of IV fluids on day one did prescribe more vasopressors. For the last part, with and between hospital differences in sepsis mortality, so a partitioning of the sum of squares analysis found that the variation explained by physician practices was approximately 4 times the amount explained by patient characteristics alone. So they then used a fixed effects regression model, which controlled for unmeasured confounding between hospitals, and researchers observed that the mortality benefit associated with the moderate fluid group was largely preserved, and that differences in the resuscitation practices between hospitals may account for a small portion of the variation in IV fluids on day one. And this is most noticeable in the very low and very high fluid groups. And as this graph would suggest, if the differences were entirely a result of differences between hospitals, then we would expect a horizontal fixed effects line. And we don't see that. We see it kind of matches the primary analysis. An additional analysis observed that the presence of patient characteristics that might either trigger or prompt withholding of IV fluid resuscitation account for only a small difference in the amount of IV fluids on day one administered between fluid groups. Physician behavior independent of patient characteristics accounted for the majority of the differences in IV fluids given on day one administered between fluid groups. And you can kind of see that here across the fluid groups, the bulk of what was attributed to the fluids that were given is seen by attending physician practice. Some of the fluid triggers we already discussed were organ dysfunction and electrolyte disorders. And again, things that would be withholding fluids included ESRD, CHF, pulmonary hypertension. So I think at this part, I'll switch off to Dr. Benabbas to kind of give her portion of the lecture.
Good morning, everybody. My name is Benabbas. I'm one of the research faculty, and today we're going to talk about retrospective studies. As always, this is an EBM lecture. We are going to talk about methodology and the study design. The goal of this lecture is not to change your practice. We're not talking about how much fluid you should give or not give for sepsis. This is not a clinical, lecture. As a matter of fact, as we are going to discuss, you should never change your clinical practice based on a retrospective study. Never accept a retrospective study as the sole evidence by which you change your practice, especially when quoted. We see this a lot. You ask like a consultant, why are you recommending what you're recommending? What's the evidence for it? And they send you or they show you like a single center retrospective study. You should never use that to change your clinical practice. And we're going to talk about why that is. First of all, what is a retrospective study? As comes from the name, is a research method in which you are looking backwards at the events that have already happened. You're either looking at charts or you're going back and interviewing people. So prospective studies begin at identifying a study subject. Retrospective studies begin after the outcome has already happened and look backwards at risk factors, at what kind of exposure the patients had, at what kind of treatment the patient got. So because you're looking back in time, because all the events have already happened, the researchers have very little control over confounding factor, over environmental effects. Like they have very little control over the course of the study because the study has basically already happened, if that makes sense. All the events have already happened, and that introduces a lot of limitations and biases, and that's the main reason you should not use this to change your clinical practice. But if retrospective studies have all these limitations and biases that we are going to discuss, why do we use them? Like, why are they ever done? So there are some benefits to retrospective studies. The biggest one is that they save a lot of time, especially if you are planning to look at large sample sizes. I'm talking about, like this paper is looking at 20% of hospitals in the entire US. If you're looking at a very large sample, or if you're looking at many, many hospitals, many states, if the pathology you're looking for just requires you to follow a patient for 20 years, that is usually very difficult and very expensive to do prospectively. But retrospectively, the data is already there and you can go back and look at it. The other scenario in which time is a factor is again something that, and this is something that needs like 20 years to develop. So if you're looking to see trends of exposure to chemicals and their possible relationship to development of cancer, so you're looking at like childhood exposures, and then you're looking at cancer when the person, development of cancer when the patient is like 50, 60 years old, that is really hard to do prospectively. For the same reason, retrospective studies are a lot cheaper. Prospective studies, randomized control trials are very expensive to do. Retrospective studies are a lot cheaper to do. The other scenario in which retrospective studies are useful is if you're looking at very rare diseases. Let's say you are studying a rare genetic disease that only happens 1 in every 500,000 births. If you need 50 kids with this genetic disease and you are trying to collect that prospectively, that might take you your entire career. But if you're looking backwards, you might be able to review all of the evidence that's out there in the past like 20 years and try to find the number of patients that you need. So those were kind of like the advantages, quote unquote, of retrospective studies. But what are the disadvantages? As we said, you are dealing with data and charts and not patients. So you are basically at the mercy of whoever at the time, like 5 years ago, 6 years ago, documented that patient encounter in terms of like clinical studies. And as we know, that means that you might end up getting a chart that has an assessment plan looking like this, or you might get a chart with an assessment plan looking like this. And these might be very similar patients, very similar patient encounters, but the documentation is vastly different because different people chart differently. And also, I don't know about you, but when I'm seeing a patient in the pod, I'm not necessarily thinking about research, I'm thinking about patient care. So I document for patient care. We sometimes document for billing purposes, we document for medical legal reasons, but we don't necessarily document for research. Nobody is documenting thinking, okay, 6 years from now, if somebody is looking at my chart for a clinical question, are they going to find the data that they need or not? And depending on who is documenting, you might get a very different chart. So one of the disadvantages of retrospective studies is that you are going to have a lot of missing data, and you have to have a protocol of how you're going to deal with that. Even the same provider might chart differently depending on how busy the department is, how sick the patient is. The exception to this is that some data points are available in every single trial. For example, in EM studies, all patients have triage vital signs, or time of arrival, or time of disposition, or ESIs. Like every single patient is going to have that data point. But when you get to history physical exam, you're going to have a lot of missing data. To streamline the process and for ease of finding patients and charts, sometimes retrospective studies use ICD-10 codes. And this is good, but only if you are sure that every single patient got the appropriate ICD-10 code that they should have gotten. And as we all know, sometimes we're busy, sometimes we get lazy, and the patients get discharged or admitted with not all of the ICD-10 codes that apply to them. So why is this not advancing? Oh, yeah. So you might have a patient that fell from a ladder and has a femoral neck fracture, and you're admitting them, and you might take the time to put all of these ICD-10 codes in, and later on somebody is looking for a chart of a patient with right or any femoral neck fracture, and they are going to find your chart. However, you might be busy, or some other provider might not put all of these ICD-10 codes in and just admit the patient for blunt trauma. And this patient is going to get missed from a retrospective study later on if all they are using is ICD-10 codes. The other issue with the retrospective studies is that even with high quality database, different group of researchers, different interpretations of the same data can happen. And depending on how you're looking at the data, what time frame you're looking at the data, what is your clinical question, what are you going to do with the missing data, you might come at vastly different results and outcomes. And this is well documented in research. Another issue is that because of all these limitations, there's also a lot of biases that are involved in retrospective studies. I'm going to go through like 3 of them just for kind of as an introduction. Recall bias is when systematically one group of patients going to their ability to remember events of the past is better than the other group for various reasons. An example of this is, let's say you are doing a study on kids with congenital heart disease, and your study process is that you go and ask the mothers of these children about their exposures during pregnancy. And then you go and ask mothers of children without congenital heart disease or any congenital defect about their exposures during pregnancy. The group that has children with congenital heart disease or any congenital anomaly is going to be able to remember the events of their pregnancy more often than the other group. And that's not because they had more exposures during their pregnancy. That's because the chances are they have spent a lot of time thinking about their pregnancy before you even go and ask them. Then there is ascertainment bias, which is when collection of data is in a way that includes some members of the population more than others. An example of this is that, let's say you are going through a database of breast cancer, and looking at the data, it looks like women who have higher socioeconomic status have more, are diagnosed more often with breast cancer. Does that mean that they're more prone to breast cancer? No, that means that they probably have the means to get earlier and better screening exams, so they are diagnosed more. That doesn't mean that the pathology more presents itself in that population. And then there's response versus non-response bias, which is when one group is unwilling or unable to take part in a research study, and this group is different than the group that is willing to participate. You are doing a study in ED 5 years or 2 years after that index visit for a chest pain. You are calling patients up, asking them if they have had any cardiac events in the past 2 years, or if they have gotten a cath, or if they have done an echo. The patient that that has housing instability, whose phone was disconnected or was just visiting US at the time and now they're back in their own country, is less likely to be able to answer your phone and be able to participate in the study that the one who has stable housing or lives in the United States or owns their home and they're still at that address. So that is non-response, response and non-response bias. The other major issue with retrospective studies is that there is no way to really control for confounding factors because you weren't there when the events happened. So everything is kind of like in the rear view, and it's really hard to know if the exposure caused the outcome or was it another confounding factor was also involved. Does this mean retrospective studies are completely useless? No, they should not change your clinical practice. However, they are useful to establish trends and to generate hypotheses. So the reason we know that smoking is associated with lung cancer is this landmark study from the 1950s in British Medical Journal. That was a retrospective study that looked at all these patients with lung cancer and found that a lot of them were smokers. So they are important, but if you're looking at them for a clinical question, you should always then go and look to see if there is any prospective study or RCT that supports the finding of that retrospective study. So now that we know what retrospective studies are and what are the disadvantages of retrospective studies and what are the advantages, let's talk about what to be on the lookout for when you are reading a retrospective study. What are the characteristics of a well-done retrospective study? So the study design need to start with a very specific predetermined study question. It shouldn't be that somebody had a database and then when they went to their a trauma database or a stroke database, and then they went to their research department and say, hey, I had this database, let's go dig in and see how many papers we can write. That is the absolute wrong way to do it. The study question has to be predetermined. There should be a protocol that has been either IRB approved or IRB exempt, but needs to have a very specific study protocol in which they tell you who they are studying, when, how. They should tell you about inclusion, exclusion criteria. They should tell you how they are planning to deal with missing data in their protocol before they even start the study. And they should tell you what statistical analysis they're going to use. And when you're reading the paper, all of this needs to be reported in their method section. Another part of the study that any retrospective study that is really important is who is going to look at these charts. So often what happens is that the research group get together and they get all of these charts from medical records, and then they're like, okay, who is going to go open all of these charts and look at them and enter them into Excel sheet? Great, we have a medical student who is really interested. You go look at all these 2000 charts. And not to say that medical students are not able to do that, but you have to understand one of the most important steps in a retrospective study is abstracting the data, meaning going through the charts and actually translating that or putting that in an Excel sheet or getting the data out. So it is very important for the authors to tell you who the data abstractors were, what training they got before they start looking at these charts, were they blinded to the research question, and if they used any abstraction forms or any formula that they were following when they were looking at the charts, and if any inter-rater reliability is established. So the best way to do is to have two people looking at the same chart and then comparing the data that they extracted. If it is not possible to have two people looking at every single chart, there should at least be some quality measure or some way of looking at the quality of work of these abstractors before you go and actually use that data. This is a study from a while ago, but I couldn't find it. It's from early 2000s, but I couldn't find like a newer one that looked at 79 retrospective chart review studies published in the 6 major EM journals. So that's Academic Emergency Medicine, Annals of Emergency Medicine, American Emergency, so good journals. In these 6 journals, they looked at 79 retrospective studies and their adherence to these kind of like quality measures that we talked about. Can you see my slide well? Because I'm kind of, okay. And what they saw is that although most papers did report their selection criteria, their variables, and all of that, when it comes to abstraction and training the abstractors, blinding the abstractor, inter-rater reliability, we still have a long way to go. And now if you compare that to 1980s and 1990s, we have made some improvement in terms of like meeting these criteria for retrospective study, but there's still a long way to go. So these are the things you want to be on the lookout for when you're reading a retrospective study. I think I might, wait a minute. Okay. So that was kind of like a very brief review on what a good retrospective study looks like. We are going to go back to Sai.
Okay, thank you, Dr. Benabbas. So now just coming back to the study, strengths of the study, based on the criteria she spoke about, I think they defined a study question prior to starting their study, so they weren't just fishing for data. In this case, what are the outcomes associated with a wider range of IV fluid administration? What's the primary driver of this variation? They did define inclusion criteria, as we discussed earlier. It's mostly ICD code based, patients going from the ER to the ICU, patients got IV fluids, antibiotics, etc. And then we went over the various exclusion criteria as well. They also defined study variables. So for them, it was IV fluids on hospital day 1, associated mortality, use of vasopressors, mechanical ventilation, need for new hemodialysis. And then they had a pretty significantly large population and also like de-identified data from patients, physicians, and hospitals. Now, with regards to weakness, I think the study question could have been more concise. I feel like the study was pretty convoluted with all these different outcomes and measures, and maybe was kind of difficult to follow along. In addition, there wasn't really a discussion of data abstractors. So who were they? How are they trained? Were they blinded? And there wasn't exactly a great protocol. Additionally, exclusion criteria may have been too vast. Too many assumptions might have been made. So they excluded patients who they assumed received fluids at a transferring facility, assumed patients who got less than 500 cc's of IV fluids didn't have sepsis, for example. Additionally, they seem to have over relied on ICD coding and that's been shown to underreport sepsis prevalence. So similar to like charting differences, right? Everyone will code differently, and there may have been patients who had sepsis but were maybe admitted for delirium or something else that were not included as well. Additionally, when it comes to sepsis and like fluid resuscitation, we usually use a weight-based fluid bolus, and this database lacked biometrics, so they weren't able to provide a weight-adjusted IV fluids on day one. Um, Additional confounders, time to antibiotics, organism virulence, source control were not accounted for. These all have impacts on mortality and sepsis. Um, and then, as I mentioned initially, the groups that we had for the final study, they were actually consolidated from uh, 9 different physician fluid groups. And so this could have exaggerated the mortality benefit that they are reporting in the medium fluid resuscitation group. Additionally, there's a lot of time spent on the variation between attending fluid groups, and this was attributed to individual physician practice variation, but they didn't really go into what that means. I mean, they're focusing on attendings, but maybe, these attendings had residents who were taking care of the patients, and maybe that played a role in how much fluids patients were given during their stay on hospital day one. So these are just some of the weaknesses that I was thinking about. So when it comes to final thoughts, so based on the study, they're saying that individual physician practice drives excess variation in the amount of IV fluids that are given. They believe that a moderate approach to IV fluid resuscitation is associated with decreased sepsis mortality based on this retrospective analysis. And they want to test this conclusion in future randomized control trials to see if we can really nail it down. And I think, having fluid analysis that incorporates patient weights would be really important for any RCTs in the future as well. Um, so that's the study, and here are my references. Back to the QR code.